disfrutado los alimentos, les haya gustado. Vamos a continuar con las partes más interesantes y las modalidades más interesantes dentro de la enseñanza médica continua, que son las perlas clínicas. Desde hace ya unos buenos años, este formato de aprendizaje, de aprender de los casos clínicos, es uno de los más atractivos, de los más aleccionadores, y hoy tenemos obviamente dos grupos de perlas clínicas, uno por cada uno de nuestros profesores internacionales invitados. Quiero comentarles, algunos de los colegas nos han pedido la manera o las instrucciones de hacer la cubeta. Por favor, si alguien desea el artículo original de Andreas Sbergal para hacer la Bucket SBD, por favor escriban a esta dirección y con muchísimo gusto les enviamos el artículo original para que la construyan. Es muy sencillo y ya ven lo útil que puede resultar para la evaluación utricular, ¿verdad? Es una evaluación de la función otolítica utricular y todas las utilidades que tiene esta cubeta que trajimos. Bueno, yo quiero robarles un tiempo antes a los profesores para mencionar un poco que el doctor David C. no es la primera vez que está en México, ya ha venido con nosotros antes. El primer curso que hicimos en el ABC en el año 2008, seguramente le recordó esta foto. Dr. David C., do you remind this photo? Bueno, ahí está David C. Aquí está Michael Halmagyi, un amigo común, Carlos Sorensen, Ricardo Arabola de Uruguay. Aquí está uno de los talleres del año 2008. Nada ha cambiado, exactamente, sigue siendo el mismo David. Después nos fuimos a Chichen Itza, un viaje hermosísimo, ahí estamos. Y David C. saliendo de una de las grutas en Balancanchen, airoso y triunfante después de haber recorrido las grutas. Y no es el Tarzán de Baltimore Tarzan Boy. Entonces, está lanzándose de la tirolesa saliendo de la selva maya. ¿No, David? Do you recall that trip? Y bueno, tampoco el doctor Strupp ha venido. How many times have you been in Mexico? 10 times. This is the 10th time. Bueno, él ha venido y esta es una foto de sus viajes previos, que ha estado en la Academia de Neuro en Mérida, aquí también enseñando la cubeta. Él es uno de los residentes, el que realmente hizo mi cubeta, Juan Carlos Morales, que es del Hospital General, debe andar por aquí. Muchas gracias, Juan Carlos. Y son unas cuantas fotos solo para recordar los viejos momentos, just to remind a very, very good moments. Please, Dr. Strupp, with your clinical pearls.
All right, thank you. So, I'm going to present you now, depending how quick you are with the diagnosis, 5, 10, 15, 20 cases. And I think this is also a good evaluation of the progress you made, not only today, but over the last years, in terms of vertigo and dizziness. So let's begin with the first patient. What type of eye movement do we examine? What is it? Smooth pursuit. Is that normal or pathological? Looks pretty good. Okay. And then look here. Let's stop that. And then move on. Hope it's working. Okay, okay. What is that? How are they? Pretty good. about the horizontal saccades? Okay. And now we see an optokinetic nystagmus. With a slow and a quick pace. This is a very elegant method to examine children. To examine patients with reduced compliance, reduced consciousness, and also psychogenic blindness. Stop here. And this one also on the vertical plane. Anything pathological? So far not. Gaze holding function. So what do we diagnose? Healthy subject. That's a challenge to end up at the end of the examination saying, this is all normal. Okay, next patient. Do you see a nystagmus? And how is the head impulse test? How do you call this syndrome? Canvas. So this is cerebellar ataxia, neuropathy, and vestibular areflexia. For many years, ideas of an association between a vestibular deficit and cerebellar disorders came up. And for instance, if you remove the flocculus, the VOR also goes down, as David has showed in 1981. I remember that paper. So there's a neurodegenerative disorder, evidently, which affects the vestibular system and the cerebellar system. And these patients are severely impaired. And we had evidence from this study on bilateral vestibulopathy, in which 25% of the patients had a cerebellar syndrome. On the other hand, if we had a look at patients with downbeat nystagmus, 50% of these patients also had a vestibular deficit, and this was the paper which gave the abbreviation CANVAS. So, now listen to this young American boy. The computer is getting tired. Oh, we need a sound. So now you can listen to two boys, and the topic is vertigo and dizziness
class
in children, which is a frequent problem.
Why do you come to the hospital, Brenna?
Vertigo.
Does it occur in attacks, or is it a permanent problem?
Attacks.
How long do the attacks last?
Probably 2 days to a week or something.
And what type of vertigo is it? Is it more postural vertigo, or spinning around, or a mixture of both?
A mixture of both.
Any additional complaints during these attacks?
Yeah, I have like a headache and loss of appetite, the inability to stay in one place or write anything unless they're hard at something.
Okay. Is there a hypersensitivity to light or sound?
Yeah,
Yeah.
probably.
And how do you behave during such an attack?
I try and like lie down and relax.
And how many years ago did the symptoms begin?
When I was probably 3 years ago.
Okay, and what's your age?
8.
8.
So at
Thank
the
you,
age
Brenda.
of 5, this young boy
That's-
developed recurrent attacks of vertigo. And here's another boy. Let's see. Okay. What is your idea about the diagnosis? Or how do you call it in children? benign recurrent vertigo of childhood?
Because I have dizziness.
Can you make it a little bit
Do
louder?
things spin around, or is it more like rocking back and forth as in a boat?
More like spinning around.
It spins, and when it spins, how long does it spin? Hours or minutes?
Minutes.
How often does that happen? Once a month, once a week, once every 2 to 3 days?
Every 2 days.
And when you're dizzy, have you noticed anything else in addition?
Headaches and nausea.
And what do you do when you're really dizzy? How do you act?
Then I'm quiet.
Then you're quieter. Thanks, you did that very well.
Okay, and then we treated the boy. He came back with his mother.
Well, Leopold, you were here 4 months ago. You'd had attacks of dizziness again and again. Then we gave you a tablet. How was it with the tablet?
Well, the first few days I still had it, and then it was only seldom, and then I felt very good again.
And okay, so what do you think? How did we treat this young boy? Which drugs can you give? For children, evidently, magnesium is quite efficient to treat benign recurrent vertigo of childhood. And if you cooperate with a pediatrician, you can also try a beta blocker, metoprolol, in a low dosage. And we have a special unit for children with vertigo and dizziness. And as you can see here, you can do all the examinations as you can do in adults. And some of the children do really feel like astronauts when they are on the rotatory chair, or when we determine subjective visual verticality. And most of the kids, they really like it. And they also like the head impulse test. I'll wait how he really likes it. So we will see how it changes. So 5 or 6 are enough. Otherwise, the compliance is not as good as it should be. So 5 or 6 are sufficient to get a good idea about the function of the vestibular-ocular reflex. So vertigo in children is really a big issue. And meanwhile, we have statistics of more than 500 kids. And about 40% of the children, they suffer really from vestibular migraine. And we have 4 children, and all 4 also have vestibular migraine. So I'm very familiar with this disease, also from home. But also, many children and adolescents, they have functional dizziness. So you can also expect that there. Peripheral is quite rare, orthostatic, mainly in young girls. Central vertigo, rare. Vestibular paroxysmia can also occur in children, and also episodic ataxia. So there are evidently differences between children and adults in terms of the relative frequency. So just a few words on vestibular migraine, because this was not mentioned so far. So it's with 11%, the most frequent cause of spontaneous recurrent attacks of vertigo. And the dilemma with vestibular migraine is that 1/3 of the patients do have attacks of vertigo only. And since there are only 2 relevant differential diagnoses, Meniere's disease or episodic ataxia, in clinical practice, it's not that difficult to diagnose vestibular migraine, even in patients without headache. What may help are that these patients often have slight central ocular motor dysfunction, and they are less pronounced than those in patients with episodic ataxia type 2. Because 90% of patients with episodic ataxia type 2, they really have a downbeat nystagmus or something like that. So that also helps. Okay, next patient. I hope the videos are running better. Better.
3 years ago, you had a brainstem infarction, and during that time, severe attacks of vertigo. Then you were free of symptoms for about 2.5 years. And what happened 4 months ago?
I have a really problem with my attacks of vertigos at the 11th of June, and it's beginning 50 times each day with twist exercises, and so
How long did the attacks last? About?
1 minute.
Okay, so we have 50 attacks per day, occurring spontaneously, lasting about 1 minute. And 8 weeks ago, we started a medication, and first you did not tolerate the medication, but what happened during the last days with the attacks?
The first time at the beginning we have really problems. I think we have more attacks and verticals, and then the last week it's going down, so I think it's only 5 times a day.
So you have not 50, but only 5 times
Yes.
a day. So there was a clear response to the medication. Thank you very much.
You're welcome.
So this patient having 50 attacks of vertigo per day after brainstem infarction with a latency, and then he responded very well to a drug. Any suggestions? You're right, paroxysmal brainstem attacks after brainstem infarction. So this is something you also find in multiple sclerosis. It looks like vestibular paroxysmia, but based on the history with the brainstem infarction, it's more likely that the attacks originate from the brainstem. The treatment is the same, carbamazepine. So, next patient, recurrent attacks of rotatory vertigo, which are induced by changes of head or body position relative to gravity, and the attacks last 30 to 60 seconds. Differential diagnosis, BPPV, or what else? Central positioning nystagmus. And I'm going to talk about the differential diagnosis. So this is now in the upright position. And now the patient lies on the left side. The diagnosis is made by an analysis of the nystagmus. In which direction? It's beating downward. This may be the right-sided anterior canal BPPV. I still have doubts about anterior canal BPPV. You see it's beating downward. It's only transient. And now the patient is lying on the right side. And if you see in different positions a similar or an identical nystagmus, it cannot be peripheral. It must be central. And this is the only clinical sign which differentiates between benign paroxysmal peripheral vertigo and central positioning. And now here, patient is lying on her back, and you see this nystagmus again beating downward. Because in peripheral positioning nystagmus, the direction of the nystagmus corresponds to the canal, whereas in central positioning nystagmus, it's a central, mainly cerebellar problem with a disinhibition of otolith signal. And this patient had a central positioning nystagmus due to an hemangioblastoma here in the oculomotor vermis. And here again, the differential diagnosis, BPPV, corresponds to the canal, whereas central positioning nystagmus not. This patient was treated with 4-aminopyridine. She responded very well, no vertigo, and the relative difference between healthy subjects and the patient became less during treatment with 4-aminopyridine. So the mode of action in this patient is via an augmentation of the physiological inhibitory input of the flocculus on deep cerebellar nuclei and the vestibular nuclei. So, next patient, 72-year-old man with progressive postural imbalance and recurrent falls. You hear this history? Any suggestions? Degenerative disorder. Okay, and again, the cue to the diagnosis, maybe even this photograph. Any ideas? With the wrinkling of the forehead. Okay, now look at the eye movements. Smooth pursuit, a little bit saccadic. And now he should look upward and downward. PSP, progressive supranuclear palsy. But he could also have a mitochondrial disorder, like chronic progressive external ophthalmoplegia. And by doing the BOR, you see that the muscles and the distal parts of the oculomotor system are working properly. It's a supranuclear problem. It's different from a problem affecting the nuclei, as in obstructions, Leucny lesion, which David showed, or in myasthenia gravis, or in mitochondriopathies, like chronic progressive external ophthalmoplegia, and these patients typically have an atrophy of the midbrain. So far, not treatable. Now look at this patient here. Vertical saccades. How are they? Normal? Okay. Are they more impaired when she looks downward or when she looks upward? Downward. So if you see that finding, there's one treatable disorder behind impaired vertical saccades. And this is Niemann-Pick type C. So Niemann-Pick type C is a disorder which initially affects the rostral interstitial nucleus of the medial longitudinal fascicle, the RIMLF. And typically, first downward saccades are impaired and then upward saccades. And this can be easily explained because we have a double innervation. Here is the RIMLF, inferior oblique, superior rectus, inferior rectus, superior oblique. We have a double innervation for upward saccades, but only unilateral innervation for downward saccades. This is something you can remember. It's evidently more difficult to move the eyes upward, and therefore nature made two connections. And this is the reason we don't know, but this is something you can remember. So typically, first impairment of downward saccades, and then upwards, and then horizontal saccades. And this disease often also manifests in children, and it's really pity if you miss the diagnosis. And a good tool to examine saccades in children is optokinetic. Therefore, you should have the tool or this nice app, which I saw there. I like it very much. Then you can see if the patient generates smooth pursuit and saccades by optokinetic testing. And it's really pity if you miss the diagnosis of Niemann-Pick type C, because it's treatable nowadays with miglustat, with pseudometabolite. And more than 95% of patients with NPC have a vertical supranuclear gaze palsy. First downward, then upward, then horizontal. So it's a key clinical feature of this treatable disorder. It's easy to diagnose on bedside examination, and it's also a biomarker for the progression and the response of the treatment. Vertical gaze palsy, it's a frequent clinical sign. If it occurs acute, you can have a midbrain stroke, intracranial bleeding, or an encephalitis affecting the midbrain. Chronic progressive, if it's supranuclear, it's PSP, MSA, spinocerebellar ataxias, paraneoplastic. They are all not treatable, but NPC is treatable. If it's intranuclear, with a pathological head impulse test, chronic progressive external ophthalmoplegia, myasthenia gravis, or endocrine orbitopathy. Now look at this boy here. We examine horizontal saccades. How are they? Severely impaired. You can hardly look to the right and to the left. So any ideas? of a disease which first affects the horizontal, and then you see the vertical saccades are quite good. The vertical saccades, so the opposite finding of NPC. It's Gaucher disease type 3. So here you have first an impairment of horizontal saccades. Again, this is a treatable disorder. The treatment is very expensive, but evidently successful. And this is what we are mainly interested in, to find treatable disorders, because the others are mainly of academic interest. But if you miss something which can be treated, it would be really pity. So, now let's talk about head shaking nystagmus. So this is a very vigorous head shaking maneuver. Okay, the nystagmus is now beating to the left. Okay, how do you interpret such a finding? A peripheral vestibular deficit on the right side. That's typical, and it's found very frequently. Now look at this gentleman here. He has just a few beats of a head shaking nystagmus. Look very carefully, 2 or 3. So you have to do it at least 15 times. Did you see it? 3 beats downward. This is called cross-coupling. And what does it indicate? Central cerebellar lesion. This is what David mentioned, cross-coupling. So if you, let's start here, have a head-shaking nystagmus, this indicates a latent vestibular tone imbalance. If you have a peripheral vestibular deficit, and you turn your head to the right and to the left, let's say my left labyrinth is not working properly, and I turn my head to the right, I get a signal. If I turn it to the left, I get no signal, or reduced signal. And this causes an asymmetrical charging of the so-called velocity storage, and then you have this imbalance, and this generates the nystagmus. If you have a cerebellar problem, then you have a vertical nystagmus during horizontal head shake. So, what about this patient? What was she diagnosed? Cervicogenic vertigo. You can see, technically, that was done perfectly well. She already had a blocking here in the lower cervical spine, then we had a blocking here, including C0. So she could not move her head anymore. The real diagnosis was vestibular migraine. She was just 37 years old, and now she has a handicap for the rest of her life. I would like to make the point that there's nothing like cervicogenic vertigo. And keep that in mind. You have always to look for something else. That's with a chance of 99% a wrong diagnosis. Okay, next patient. Listen to his history, and then try to make the diagnosis. What are your major complaints?
I have a flickering eye on my left side.
Flickering image, flickering eye on the left side. Oscillopsia, monocular oscillopsia. Any suggestions? Monocular. What's behind monocular oscillopsia? Any ideas? You're right. A monocular nystagmus. This is something you can see here. You see this rotatory vertical nystagmus. It's very tiny. And if you examine the same patient with your ophthalmoscope, you see it much better. So he has a vertical torsional nystagmus. Which eye muscle generates vertical torsional eye movement? It's the cochlear nerve. And this patient has a posterior oblique myotonia. Just keep the leading symptom in mind, monocular oscillopsia. Patients have a vertical rotatory nystagmus, which can be induced by hyperventilation. And the mechanism is like similar to all other neurovascular cross-compression syndromes. Now there's a compression of the trochlear nerve, and treatment is boring because it's the same drug. And in rare cases, you can do surgery if you identify the site of the compression. Another patient, 60-year-old lady. For 5 years, she has postural imbalance and dizziness when standing. The symptoms worsened when standing for a longer time. The symptoms improved when walking. And she had no symptoms when running or sitting. What are your differential diagnoses in such a patient? Phobic postural dizziness. As for phobic postural dizziness, this is the most important differential diagnosis. It's quite unusual that the symptoms go away when they walk, and they often still feel dizzy. Any other differential diagnosis? So when she was standing, after 1 or 2 minutes, she felt really dizzy. Then she walked a little bit and everything was okay. Orthostatic tremor. If you do posterography, who of you has a posterography? Very few, I assume, therefore it's useless. You show the results and you do a frequency analysis. You get a typical peak between 14 and 16 hertz. But what many neurologists have, and there's definitely a neurologist in your neighborhood, they have superficial electromyography. And what you can simply do is to put an electrode on the anterior tibial muscle and the triceps surae, and then you use superficial recording. And then you get the same results. You see here, patient in a sitting position, nothing. Patient standing, you get a very high frequency discharge simultaneously of the agonist and the antagonist. So that's a very simple way to diagnose orthostatic tremor. No machines necessary except a regular superficial EMG. And one way to treat it is this rucksack position for sitting. I don't know if this is practical for a dinner party, but you should be aware of this differential diagnosis. Tell the patient what the problem is. Some of these patients respond to benzodiazepines, others to beta blocker, and it's evidently mainly a cerebellar problem. There the rhythm comes from. So, now look at eye movements. What is that? Okay, once again, quick look at these horizontal eye movements. You saw a similar patient before, and here is another patient. Okay, you're right. So this was an opsoclonus, and this is ocular flutter. Okay? Ocular flutter is mainly in the horizontal plane. Opsoclonus often in all directions. Eyes closed, eyes open, eyes closed. So that's a typical opsoclonus. And ocular flutter. Now the next patient comes into your office, 56-year-old, otherwise healthy man. He has the following symptoms. When turning the head to the left, he got a severe rotatory vertigo and a buzzing in the right ear. And you could always reproduce that. When you examine the patient, you got the following finding. After about 5 to 10 seconds, once again, you got a nystagmus. Once again. Okay, he does not tolerate that very long. Is that cervicogenic vertigo? What is it? rotational vertebral artery occlusion syndrome, something very rare. So most of the cases have been published because it's really rare. What's happening if you turn your head to the left? In everybody of us, there's a compression of the right vertebral artery and vice versa. And if you have a situation in which your vertebral artery blindly ends in the posterior inferior artery, like in this patient, and the patient turns the head to one side, then he runs into trouble. So in this patient, there was a compression of the right vertebral artery when the patient turned the head to the left, and the left vertebral artery blindly ended in the posterior inferior cerebellar artery. So there was no blood supply to the basilar artery and to the right labyrinth. And this led to transient ischemia of the right labyrinth and brainstem to the blind ending left vertebral artery. So to diagnose rotational vertebral artery syndrome, you need an MR angiography or an angiography showing a blind ending vertebral artery. Otherwise, you cannot diagnose that. This patient was treated, and he recovered and had no symptoms now for many, many years.
Could you please describe the complaints that brought you to us?
It began with red eyes.
Can you
Then
increase the
2 days
sound level a
later,
little bit?
I also had nausea, vomiting, dizziness. The ears were closed.
Maybe we repeat the video. Once again.
Could you please describe the complaints that brought you to us?
It began with red eyes. Then 3 days later, I also had nausea, vomiting, dizziness. The ears were closed. There was a buzzing in the ears, and then I can...
What kind of dizziness was it that you had at first?
A rotatory vertigo.
What complaints developed in the course of time?
On medication, the dizziness improved, and the buzzing in the ears became fainter. Since then, I've had tinnitus, and I hear worse in the right ear.
Any other complaints that occur in everyday life?
Every now and then I have attacks of vertigo, but that's all.
And when you are walking or moving?
Everything's okay, actually. I have a slight feeling of instability every now and then, but so far it's something I can live with.
Thank you very much.
So luckily this patient was under treatment. All began with eye problems, red eyes, then dizziness, attacks of vertigo, tinnitus, hearing problems. Any ideas about the differential diagnosis? Eyes and ears problem at the same time. It should be a red flag for you. It's Cogan syndrome. So what you can remember is a double triple, and you should remember that because it mainly affects young adults. If they are not properly treated, in a few moments I show how, the majority of them develop bilateral vestibulopathy and they become deaf. So keep in mind, if a patient complains of eye problems, hearing problems, and dizziness, clinical findings are interstitial keratitis, bilateral hearing problems, bilateral vestibular problems. The mechanism, we also evaluated that, is a T and B cell mediated immune reaction, and you can only preserve hearing and vestibular function by an early and very aggressive treatment. So 1 gram methylprednisolone at least for 5 days, and most of the patients have a chronic course that need cyclophosphamide or azathioprine. And here was a small case study from the Netherlands, published many years ago, which illustrates how important an early treatment is. So, if the delay of treatment was more than 2 weeks, only 10% of the patient had an improvement of the hearing, 90% of the patient became deaf, and bilateral vestibulopathy. So, once again, keep in mind, young lady comes with dizziness, hearing problems, and eye problems. Ask the patient for eye problems. It's often misdiagnosed as a minor eye problem. Keep that in mind, treat the patient, You can only win and not lose anything. So, look at this patient. What is that? You see a quick and a slow pace. What type of nystagmus? It's what? Congenital is conceivable. Any other differential diagnosis? In congenital, you most often have a zone with a minimum of nystagmus. It's pendular, acquired pendular nystagmus. So, most often pendular, mainly horizontal, but it may also be mixed. The frequency is 2 to 8 hertz. And as David already showed, there may be additional symptoms depending on the side of the lesion. The patient has internuclear ophthalmoplegia, ocular palatal tremor. They may have ataxia and a rubral tremor. And this is best to repeat this neo-molare triangle with a lesion and leading to a pseudo-hypertrophy of the inferior olivus. And in the past, some of these hypertrophies have been biopsied, misdiagnosed as a tumor, and most often it's caused by bleeding here in the pons. We were thinking about a treatment with a gamma knife, but some people think this is too risky. I have a different opinion on that, because these patients have severe osculopsia. No drug is effective. We've discussed that. Medical treatment is possible in some patients effective. Gabapentin, memantine, or a combination of both. This is from John Lee's view. So memantine or gabapentin. Now just for you, a few examples of eye movements to get an idea. What is that? How do you call this nystagmus? Convergence retraction nystagmus indicates a midbrain lesion, mainly affecting the posterior commissure. So if you see that, you can be sure there's a midbrain lesion which can be very tiny, leading to this convergence retraction nystagmus. Now look here at this patient. Just look at the nystagmus. He's now looking upward, and the quick face is beating upward. He also has a skew deviation and exotropia. Now he's looking downward, and the quick face is beating downward. So it's not an upbeat or a downbeat nystagmus. It is what? A vertical gaze-evoked nystagmus. What does it indicate? Where's the site of the lesion? The INC, interstitial nucleus of Cajal. This is the gaze-holding center for vertical eye movement. Now here, you saw that before, it's just repetition. Okay, what is it? Seesaw nystagmus. Okay. You see how much you have improved your knowledge. What is that? Okay, downbeat nystagmus. And to diagnose downbeat nystagmus, patients have always to be examined during lateral gaze. So this increases the intensity since it is accompanied by a gaze holding deficit. Now here another patient is looking to the right. You see a gaze evoked nystagmus to the right. Now look what's happening when he's looking to the midline back.
Tiefer halten.
So now the nystagmus was beating, quick face to the left. Now he's looking to the left, gaze evoked nystagmus to the left. You have to do that for 20, 30 seconds. And then the patient has to look back to the midline position. And now it's beating to the right. What is it? It's a rebound nystagmus, and it indicates a cerebellar dysfunction, mainly affecting the flocculus.
Gerade ausschauen nochmal.
Okay, so I think that's it for the moment. and O we skip. Then at the end, I'd like to show you a short animal experiment. So a rat after labyrinthectomy, and then half an hour later with a truck. What's the magic truck? You see the difference? This would be ideal for symptomatic treatment of acute attacks. And the magic truck is 4-aminopyridine. So we currently evaluate the truck in humans. Okay, and what we've all done in Munich is teamwork. And so this is the inner circle of my team. Most of them have grown up, but these were photographs I selected from our young team. Thank you very much for your attention.
Amigos, este es el momento en donde quienes deseen acercarse a los profesores a la ronda de preguntas, por favor, hay 2 micrófonos puestos en los pasillos. Creo que es una oportunidad inédita, en verdad envidiable, de tener la oportunidad de preguntarle al doctor Michael Stupp cualquier cosa relacionada con los tópicos tomados el día de hoy, o cualquier cosa relacionada también con con la neurología en sí, o cualquier duda que ustedes puedan tener. Por favor, anímense. ¿Alguna pregunta?
Okay, we would need a microphone.
Gracias, doctor.
Thank you very much for your excellent talks. I have a question regarding how do you talk to your radiologists to do your MRIs? Are you using 1.5 Tesla? Are you using 3 Teslas? How often do you correlate your clinical finding with your radiologic findings? Because we have a lot of problems pinpointing the midbrain or medulla or whatever lesions.
That's an important question. So the expert on MRI and labyrinth is David Z. Inducing severe vertigo in the scanner, but that was not your question. Well, as an experienced examiner, you are better than your neuroradiologist. This is true, for instance, for an internuclear ophthalmoplegia. Clear diagnosis, you see a lesion only 90%, even with the best technology. This is also true for vertical gaze pulses and things like that. So most often, you don't need an MRI to confirm your diagnosis. Too many MRIs are done. This has the consequence that those who need an MRI have to wait too long. So this should be really limited. If you have a patient with acute vertigo and dizziness, and you have a clear central sign, then a CT is absolutely sufficient to exclude bleeding. And then you treat the patient with aspirin and simvastatin. Stroke is so trivial and extremely boring because 95% of the patients get the same treatment. This looks always spectacular. Big conferences about stroke, it's really boring. If you go into clinical practice as a neurologist with a big stroke unit, you see 2,000 patients per year and 1,900 of them get the same drug. So there's nothing special. And you should not be afraid of stroke. CT, excluded bleeding, aspirin, and that's it. So too many MRIs. Good and important question. There was another question.
Doctor, ¿qué pasa cuando tenemos pacientes que tienen una prótesis ocular o bien que no tienen un ojo? Pacientes con un solo ojo.
Okay, that's a good question. The question was about an eye prosthesis or patients who have only one eye, examine the other eye. The same is true in patients who have an eye muscle problem or an eye muscle nerve problem. To look if they have a central problem, they should cover the impaired eye and examine the other eye. So one eye is enough for the examination. Another problem are patients who are blind. They're really difficult to diagnose. That's really a big issue. Then we have the Romberg. We can have vestibular evoked myogenic potentials, the CVAM, but that's it. So in other words, the eyes are really the window through which you can look into the brainstem, the cerebellum, and the labyrinth. And if the window is closed, it's very hard to make a diagnosis. So therefore, a very important question. Please.
Doctor, con respecto de los lentes de Frenzel, ¿qué características debemos tomar en cuenta en cuanto a las dioptrías o la lente como tal debe tener algún ángulo? Alguna vez preguntando en tiendas de lentes, me preguntaban que si lo necesitaba con un polo positivo o negativo. Supongo que eso es en el ángulo o la concavidad del lente, pero ¿qué características debiera tener si quisiéramos hacer unos lentes de Frenzel?
Okay, you can use simple lenses with 16 diopters. 16 diopters, 16 to 20. And if you have only these glasses, you can cover one eye and look through the simple glasses with the 16 diopters. So you don't need the expensive glasses, you can just use the regular ones. Regular lenses, 16 diopters, plus 16.
Los que usted tiene, la mica, es...
M-glasses.
¿Así se venden? O sea, ¿tienen una característica especial?
Well, of course they are sold, and there's also a small company which sells them. So if someone's interested, you can send me an email, and I can send you one for a reasonable price.
Una buena sugerencia, ya que nos visita tan seguido, sería bueno que trajera usted y verá cómo va a tener buenos clientes aquí.
Okay, that's a good issue. I already talked to Abbott, and maybe they develop a package with the examination bucket, with the M classes, or Miguel's glasses, you can call them. And we also have a pocket guide for eye movement disorders and a pocket guide for vertigo, and would be ideal, but this is something I tell now for the 10th time, to translate it into Spanish. And then you have a pocket guide for eye movements, pocket guide for vertigo, the M classes, and the bucket set. That's all you need. So maybe they discuss it here internally. It's not my business.
Muy bien, vamos a estar insistiendo con Abbott. Gracias.
Okay.
Doctor Rojo.
I support you.
Hola, doctor. Realmente son dos preguntas. La primera es, ¿ustedes qué tiempo dan para evaluar la rehabilitación vestibular que recibió el paciente, la respuesta al tratamiento? ¿Y qué tiempo dan? ¿Y qué herramienta ocupan ustedes para evaluar las deficiencias que quedaron? Esto con un fin médico-legal. ¿Qué parámetros utilizan después del tratamiento para evaluar la respuesta y evaluar las lesiones?
Okay.
Y me falta otra pregunta.
That's an important question. So patients with bilateral vestibulopathy or severe unilateral vestibulopathy, they need a lifelong rehabilitation. This does not mean that they have to go to physiotherapists every day. So let's say for 4 weeks to physiotherapists, and then we have folders, which can also be distributed by Abbott, for our patients, and they should do the exercises by themselves every day. 15 minutes every day. Because if they stop doing that, they will definitely become worse. So that's very important for them. Another question is legal issue in terms of vestibular deficits. Yeah, that's an important question. For instance, if you drive a bus and have recurrent attacks of vertigo, or if you are a pilot with recurrent attacks of vertigo, you are only allowed, at least in Europe, to do that when you're 5 years free of attacks. If you have recurrent attacks of vertigo, Meniere's disease, paroxysmia, whatever the cause is, and you have a driving license, you have to be free of attacks for 1 year because you are allowed to drive a car again. If you have a unilateral deficit, you can drive your car, even work as a pilot for Lufthansa with one labyrinth. And if you have a bilateral vestibulopathy, there are certain jobs which you cannot do. So in most cases, it's not that difficult.
Sí, doctor Rojo, otra vez.
¿Y ocupan alguna herramienta dentro de las pruebas otoneurológicas para evaluar las secuelas? ¿Ocupan videonistagmo, ocupan HIT o posturografía o el conjunto de las tres o algún otro parámetro para evaluar esas deficiencias que quedaron?
Okay, if a patient comes for such an evaluation, we use the whole battery of tests we have. So, calorics, head impulse test, posturography, gait analysis, O and CBAM, and clinical examination. And this will take 3 to 4 hours. But then we have a good idea about the quantitative function of the vestibular system. But you have many patients with attacks of vertigo with no deficits. So then the history is even more important. So it's a regular approach, but a little bit more detailed and sophisticated than in the usual patient.
Perdón, voy a abusar. Doctor, nuevamente, y en cuanto a estos parámetros, ¿tienen alguna tabla que diga tantas alteraciones le toca un 20% de pensión, 3 alteraciones le toca 10? ¿No tienen ustedes un parámetro así establecido?
No, it's always a decision on individual basis. So, and you have to look for the functioning of the patient, the quality of life, and all the things. So, there are no strict criteria.
Y así la última. Perdón, voy a usar el doctor. En cuanto al nistagmo de los mineros, doctor, ¿usted ha tenido casos de nistagmo de los mineros?
About what?
Nystagmus miner. ¿Sí ha tenido usted casos de nystagmus miner, nistagmo de los mineros?
Minus nystagmus.
Just for intoxication, perhaps for plum intoxication.
Yes.
Yeah, very quickly, Miner's nystagmus is probably a form of visual deprivation nystagmus in patients with a genetic susceptibility to it. Well, this is even better. It's important to remember vision and changes in visual inputs can lead to nystagmus because the brain doesn't have a mechanism to keep itself calibrated. Congenitally blind patients have nystagmus. There's never been any visual input to keep the eye movements coordinated and to generate fixation reflexes.
Any further questions?
Well,
muchas gracias.
Siguiente pregunta, por favor. 2 preguntas más.
Hello, Herr Professor. ¿Todos los pacientes con nistagmos necesariamente tienen vértigo?
No, not. So it's typical, for instance, for patients with congenital nystagmus, although they have a very severe nystagmus, that they have no complaints, they have no oscillopsia. And the reason, therefore, is that their ability to see a moving target as a moving target is reduced. So there are processes of adaptation that they don't have any oscillopsia or dizziness, which may decompensate during aging, but that's a typical feature of congenital nystagmus. Renounced nystagmus, almost no symptoms.
Okay. Another question. ¿Cuál es la dosis de magnesio para los niños?
So the limiting factor in magnesium is diarrhea. So there are some chewing gums with magnesium, which are highly appreciated by children. So we give dosages between 1 and 300 milligrams.
Thank you.
Inara.
Hi, doctor. I've been treating Meniere's disease very successfully with a diet, with acetazolamide and potassium salts. Should I change the way I treat?
I'll never
Meniere's
change your
disease
winning
patients?
team. You're a good doctor with a great placebo effect.
With a what, sir?
Good placebo effect.
Well, some patients come to me with acute attacks of Meniere's disease. I give them the treatment and they improve.
Yeah, well,
So-
as you know, the natural course of Meniere's disease is highly variable. So you have patients who have 3 months with 15 attacks and then 6 months nothing. That makes clinical trials in Meniere's disease so difficult. So all the studies did not show an effect of salt-free diet, of diuretics, or acetazolamide. Otherwise, we would use it. Cochrane reviews on this topic were crystal clear. No effect. In particular, the studies on salt-free diet, they are from the 80s. Few cases described horrible. The only thing which happens is that the patients lose weight because they have less appetite. So that's an interesting and good effect, but that's it.
Okay. Thank you.
La última pregunta, gracias.
Doctor, no se ha hablado de los acúfenos pulsátiles. Tengo un paciente con un acúfeno bilateral pulsátil que aumenta con el ejercicio y pues he pensado en glomus yugular o glomus carotidio, pero en los estudios no se ha encontrado nada, únicamente una hipoacusia conductiva de un lado, no me acuerdo cuál, pero la resonancia y no he encontrado en qué puedo pensar o qué más puedo hacerle. Angioresonancia no he realizado.
There's only one serious disorder. As a neurologist, I can tell you, I recently had a Rotarian friend. He had seen about 10 experts on tinnitus, and he ended up with an arteriovenous fistula. He had a pulsatile tinnitus. So that's the only serious disease. An MRI, except you have a very pronounced high-flow fistula, does not show anything. If you have a high-flow fistula, you see dilated sinus and venous. You need an MR angiography with an arterial and a venous space, but the gold standard is a conventional digital subtraction angiography. So if you have a patient with a clear pulsatile tinnitus, the first thing you need is stethoscope. In this patient, I could make the diagnosis through the telephone because he put his phone behind his ear, and then you clear diagnosis. It's seen by real experts in Munich on tinnitus, and nobody examines him properly. So that's the only serious condition. Pulsatile tinnitus, look for arteriovenous fistula. Many of these patients had a minor sinus venous thrombosis with a recanalization, and then they developed this fistula. And that can be easily treated by endovascular surgeons or by neurosurgeons. And anything else is la pola.
No le escuché el pulso, no le escuché, pero sí se ve el pulso en uno de los lados. Y es bilateral.
That's probably support. So this patient should go to a neuroradiologist and needs a digital subtraction angiography.
Muchas gracias.
Muchísimas gracias, doctor Stuck. Ha sido un placer tenerle. Vamos a despedirlo, por favor, con un gran aplauso.